And then Sway, are you able to take over the whiteboard or to screen share?
Yeah, 1 second. Let's see if I can find it. Thank you. Can you see my screen?
Not yet. There we go.
Perfect.
All right. Travis, take us away.
All right, perfect. So first aliquot is going to be a chief complaint. We have a 64-year-old female who is presenting to the emergency department with abdominal pain.
All right. Well, I will just say that the original chief concern of acute abdominal pain coming into the emergency room, while the list is vast, it's going to require us to sort of focus on a few of the life-threatening causes up front. And I would say one of the things that I'm also noting in addition to the chief concern that we have is who this chief concern is, or is who the person who has this chief concern is. I'd say one of the best pros that I've learned from one of my mentors here, Dr. Gurpreet Dhaliwal, is that the only typical presentation of an elderly adult with abdominal pain is an atypical one, which is to say that as somebody gets older, our sort of classic illness scripts for severe intra-abdominal catastrophe start to break down, and we realize that there can be a huge range of presentations for severe intra-abdominal disease in anybody who is elderly. And so I think from that perspective, right, anybody who is older coming into the emergency room with abdominal pain warrants a thorough evaluation for any of those severe life-threatening causes. And then the question is, well, what are those life-threatening causes? And I think the mnemonic that I like to use is VIPO. So the V would be vascular causes, and that we can sort of double click on vascular and say that there is a MI, an MI, an AD, and then an A3. So 2 MIs and 2 As. The first MI is actually a myocardial infarction, right? We know that while MIs can traditionally present with chest pain, we also have to be open to the possibility that a myocardial infarction will present with abdominal pain. The other MI is mesenteric ischemia, which could manifest either as a subacute process or an acute process. The A3 is an abdominal aortic aneurysm, and then the AD is an aortic dissection. So those are going to be the sort of 4 life-threatening vascular causes that can present with acute abdominal pain. Again, mesenteric ischemia, myocardial infarction, aortic dissection, abdominal aortic aneurysm. The I is going to be basically itis. So you take any organ within the intra-abdominal compartment and add itis onto the end, and that can cause acute abdominal pain, right? Cholecystitis, pancreatitis, enteritis, cholangitis, right? The list is super long. And then the P is going to be perforation or obstruction. And I'm going to turn it over to Kirtan to talk through sort of the perforation or the obstruction category in the setting of somebody who has acute abdominal pain.
Sure. So, Jack has laid down the beautiful framework, and I totally agree with Jack that VIPO is something which is very important. And, we have a beautiful schema on our website as well. So please, if you can check it, then it would be great. And about the perforation, we also need to ask ourselves that is the patient, hemodynamically stable or not? Because often it happens that whenever you have the perforation, be it the stomach, be it small bowel or large bowel, the patient may be hemodynamically unstable. So in such situations, the management take precedence over the diagnostic steps. So I would always keep in back of my mind that how is the patient doing, And then finally the obstruction, again, we have to ask ourselves that what if the patient had some obstructing lesion for long, and now that obstructing lesion has, completely obstructed the lumen, and that's where we are getting the acute presentation. So always, sometimes, what seems acute may not be acute. So we have to ask ourselves that could this be chronic process which has now become acute because of the complication? So that ends our VIPO part. And then I was looking in the chat that, my dear friend Jasimran mentioned that whenever we have a female, then we have to ask ourselves that is this abdominal process related to some abdominal organ apart from the GI tract? Like what if there is involvement of reproductive tract system, right? And from previous episode, I remember that Jack had taught me actually that whenever we are dealing with abdominal pain, we have to ask ourselves that whether the pain is coming indeed from the abdomen or somewhere else. Like could the pain be originating in the thorax, as he beautifully told about the MI thing. And could the pain be in the genitourinary thing, like the involvement of prostate is there, the involvement of reproductive tract system as we alluded to, and finally from the spinal cord processes, because sometimes, all the nerves and everything which can pass from the spinal cord and around the anterior abdominal wall can present as abdominal pain. So I think having this framework is important in mind so that we don't anchor only into the abdominal system, and we also keep in mind the other systems we can manifest as abdominal pain. So I think this is a good place to stop, and maybe I can ask our dear friend Travis to share the next aliquot.
Perfect. For this next aliquot, I am going to include a brief HPI and some review of systems. The patient notes worsening constant kind of diffuse abdominal pain that has gotten worse for about the last 3 days. She complains of nausea, vomiting, and some non-bloody diarrhea as well at the onset. She notes her last bowel movement this morning was semi-solid. Her pain, she says, is achy, crampy, and sharp. It's all of the above. It's nothing really specific. At the onset of the pain, she noted it was in the right lower quadrant and radiated to her back, but then it kind of became more diffuse. She notes the pain does not get better with anything, and the symptoms are exacerbated by eating, movement around, just walking around, and change of position. She denies any similar symptoms to this in the past. Some other notable review systems, she feels weak and fatigued. She denies fevers or drenching night sweats. She notes, like I mentioned before, in addition to the abdominal pain, she denies any rectal pain or any kind of gross GI bleeding. She denies chest pain, shortness of breath, or coughing. And she denies any urinary symptoms like dysuria, urinary frequency, flank pain, or hematuria. And her past medical history, I'll just give you a little bit. She has hypertension. She uses tobacco 1 pack per day for about 40 years. She occasionally smokes marijuana as well and uses alcohol on a social basis. And surgical history is notable for a hysterectomy. And she takes no medications and has an allergy to naproxen, which she says gives her anaphylaxis. And that is the end of the second aliquot.
Amazing. Thank you so much, Travis. Kirtan, I will leave it to you to take us away with what has actually been, I would say a very, very rich HPI that we have here.
Sure, definitely. So, before I jump into my thoughts, I see in the chat that Jasimran has some amazing idea. So Jasimran, why don't you unmute yourself and share your thoughts first, and then I will layer on to your thoughts.
Okay. First of all, Travis, can you recall, does the pain exacerbate on eating as well after eating food?
It does. Correct. It does.
So,
Eating and moving around. Yes.
okay, so eating is one of the component in which, like, if a colicky pain is there and we eat something, like if gallbladder needs to secrete out some secretions and there is some kind of a blockage. So against a blockage, if a lumen is trying to contract, that is what a colicky pain. And its character is normally aching, sharp, acute, and one of the common presentations to visit ED. So I was just trying to delineate the characteristic of the pain, as well as when it comes to the pain which is radiating to the back and diarrhea, I thought of some kind of a pancreatic involvement. So a lot of, if an exocrine component of pancreatic is involved, so it can present in diarrhea as for the neoplasms, acute pancreatitis, all those things, and it can radiate to back. And now in past medical history, marijuana use and alcohol, these are one of the common causes of pancreatic abnormal dysfunction. So definitely pancreas will be in my back of my mind as well. Thank you.
Sure. Thank you, Jasimran. I agree with your thoughts that how involving pancreas is a critical part of our problem representation. And talking about the PR, I wanted to emphasize that if we want to frame the PR at this point in time, that what will involve in our PR? So we'll definitely involve that this is a 64-year-old female, and now she is presenting with the right lower quadrant pain, which was initially achy in character, but is now radiating to the back and is exacerbated by the movement and the eating component. So the eating component was tackled by Jasimran, and now I can maybe a little bit talk about the movement component. So as I have learned that whenever you have pain which is exacerbated by the movement, then we have to be vigilant about the involvement of peritoneum. Because if there is peritoneal irritation, because the classic things that we have learned in medical school is that whenever there is peritonitis or peritoneal irritation, then the patient would be lying standstill. Like the patient won't be moving at all because even the slightest movement can cause the pain. And again, peritoneum wraps all around the abdomen. And the fact that Travis mentioned that the pain is diffuse now, so that makes me worry that what if there is indeed peritoneal involvement. And the past medical history is also relevant because if you think about it, and one of the most common cause of obstruction is the adhesions which have been remaining in the abdomen since past surgery. And as Jack mentioned astutely in the first aliquot itself, that we have to worry about the VIPO. And in that, the O and the P part are related to hysterectomy. Because if the patient has undergone hysterectomy, and now let's say the patient had some adhesions in the bowel wall, so it is possible that maybe those adhesions have caused the bowel obstruction and that has subsequently ruptured and causing the peritoneal irritation. So that is something that I am thinking about. And Jack, before we involve the chat further, what are your thoughts, Jack? That what am I missing at this point?
I think Perton, your discussion is absolutely phenomenal. The only thing that I think is also coming into my brain is sort of the pattern by which this pain progressed. And so if we think about the fact that this started out as a localized pain, Sawyer, do you mind? I think that the case is coming up. I'm going to try to look away from it, but I just want to make sure that we're not giving the answers away here. So I think if we look at the ways in which the pain progressed, I think this becomes important because this started out as a focal pain and then that pain became diffuse. And normally, if we think about intra-abdominal processes, the pathway is oftentimes reversed. For example, when I had appendicitis when I was like around 11 or 12 years old, my appendicitis started as a diffuse abdominal pain, and then it localized into the right lower quadrant. And the reason for that is that we don't have great innervation of our visceral peritoneum, right? So our visceral peritoneum is not going to have good localizing features. Abdominal pain will manifest diffusely. So when the appendix or the pancreas or the stomach is inflamed, will sort of manifest maybe in the upper abdomen or in the epigastric space, but it won't necessarily be localizing. Then once the parietal, or I guess not the parietal, but once the outer layer of the peritoneum gets inflamed, that has much more direct innervation. So let's say for me, my appendicitis, once the outer part of my peritoneum got inflamed, then it started to localize into the right lower quadrant. So normally we see diffuse abdominal pain that then starts to relocalize into a specific area. In this case, this started out in the right lower quadrant and then became diffuse. And so I think the question that we have to ask ourselves is, why has it become more diffuse? Has it become more diffuse because this focal process started to develop and sort of progress throughout the abdomen? One of those things could be if there was a perforation like Kirtan mentioned, and we're now dealing with peritonitis. So we started out with an organ-based itis and then actually got inflammation of the entire peritoneum. And so I think that that's one thing to think about here is not only where did this start, but also where has it progressed? And the way that the pain is progressing makes me worried about there actually being peritonitis here, as opposed to just a single organ-based inflammatory process. All right, Travis, I'm going to kick it back to you to take us further.
You got it. I'm gonna take the hit for Sawyer. I sent him the link just in case there's something to fill in. And I've done it before where you click on it and it opens up when you're sharing. So Sawyer, I'm so sorry.
No,
Gosh.
I'll be honest. It was one of the I oftentimes wish that we could see the answer. And I think I was lucky to, as soon as I saw that pop up, I was like, I'm gonna turn away. So I still feel blinded to the case. And I think Kirtan is much more honest than I am. So I suspect he also is too. So I think we're good.
Yes.
Oh, great. So my fault, Sawyer. I'm so sorry. So I'm going to give you guys the physical exam, and if you, I'm just trying to think. So I'll do the physical exam here, and I'm going to do the first set of labs, and then the next aliquot will be some imaging and other results. Okay. So our exam vital signs: blood pressure was 119/66, heart rate was 82, respirations were 18 a minute. O2 sat was 95% of room air. Oral temperature was 36.9 Celsius. She is a 55 kilogram female, so she's a small lady. On exam, generally, she's in severe distress. She appears ill and very uncomfortable. Her skin exam, skin is warm and dry. There's no pallor or bruising or anything anywhere, no rashes. Cardiovascular exam is normal, regular rate and rhythm. There are no murmurs. There is no abnormal peripheral perfusion abnormalities. Cap refill is normal. There's no pedal edema. Her breath sounds are equal, non-labored. Abdominal exam. Her abdomen appears distended. She has severe generalized tenderness to palpation in all 4 quadrants. There is guarding present. There are high-pitched bowel sounds noted as well. And upon kind of movement of the stretcher, she notes pain everywhere. Neurologically, she's alert and oriented to person, place, and time. There are no neurological deficits. First set of labs, her CBC showed a white blood cell count of 16,000. Neutrophil count was high at 91%. Lymphocyte count was low at 6%. There were no bands present. Her hemoglobin was 15 grams per deciliter, and her platelet count was normal at 274,000 cells per microliter. Her chemistry panel, a CMP was sent. Her sodium was 133, potassium was 4, chloride was 91, her bicarb was 28, glucose 161, BUN 23, creatinine 0.9, and calcium was 9.6. The one good electrolyte that can cause abdominal pain if elevated. Total bilirubin was 0.9. Total protein was 6.6. Albumin 3.8. Alk Phos was normal at 72. AST was normal at 12. And ALT was normal at 12. A lactic acid was sent and returned elevated at 3.2. A lipase was normal at 7. And a troponin was also drawn and sent. It was normal. And that is the end of this third aliquot.
Well, I will maybe, given we just got, I think, some really, really critical clinical data here, I will focus on sort of thinking through the physical exam, and then I'll turn it over to Kirtan to talk through some of the different lab findings that we have. But I think, in terms of the exam, I think we have some discrepancy here, right? We have vital signs that look to be relatively stable, but then multiple features on the clinical exam that are actually quite concerning, right? So I think we have to ask ourselves, like, which one are we going to put more stock in? Are we going to say we feel okay that she is hemodynamically stable, or we feel quite concerned given that we have the severe distress and these quite concerning abdominal exam finding? And I will say that, when oftentimes when people come into the emergency room, or when people are coming into the hospital with a clinical illness, there has been some time for the hemodynamic status to catch up with the clinical status changes, right? If you've ever had a patient sort of decompensate before your eyes at the bedside, we'll oftentimes see signatures of the decompensation happening in terms of our physical exam before we see it reflected in some of the various hemodynamic compensations. And so one of the things that I'm wondering here is the exam telling us what is about to happen systemically for this patient? Because our exam has multiple features of developing systemic illness as well as of peritonitis, right? She appears ill, she's in distress. And then we have the abdominal distension, diffuse abdominal pain, and then this sort of key word that Travis gave us in the history, which is that when we shake the bed or rattle the bed, that pain gets much worse. And if we think about what happens when somebody rattles the bed, right, all of the organs inside of our abdomen are going to move a little bit. And if that peritoneal space is quite inflamed, those organs moving within our peritoneum, it's going to be quite painful. And so I think we have exam findings that are suggesting that we have that this patient has developed peritonitis. And then I think even though the vital signs are stable, we have to be concerned about the fact that they may not be this stable for very long. And so I think the exam really escalates the urgency with which we need to find an answer in terms of what's causing this ultimate I should say what's causing these exam findings that are suggestive of peritonitis here. So I think the take home here from the exam is trust what you're seeing in front of you, not what you're seeing on the monitor, because what you're seeing on the monitor may very quickly reflect what we're seeing in front of us on the exam here. But Kirtan, what are you making of some of the labs we have?
Sure, amazing thoughts, Jack. And in fact, your discussion has shaped my thinking now. So if you think about it, if we have the peritoneal irritation, then peritonitis. So whenever we see the eye test, then we have to, immediately look at the WBC, because what is the marker of inflammation? It's the neutrophilic leukocytosis. And fortunately, we have that in our case. And the reason why I'm telling fortunately, because sometimes it can happen that we can have lymphocytic leukocytosis or, monocytic leukocytosis, and that always warrants a suspicion for more sinister etiology. So the fact that we have neutrophilic leukocytosis kind of, reassures us that our initial hypothesis of peritonitis might be the true thing. But then, again, coming back to what Jack had mentioned in the earlier paragraph, that what if the patient had, appendicitis or some sort of inflammation in the right lower quadrant, then which subsequently, kind of became diffuse. And that is certainly a possibility because, if you think about it, be it appendicitis, be it diverticulitis, or be it even colitis, then it can lead to elevation in neutrophil count. So that is something that we have to ask ourselves, that is that possible? And finally, about the lactic acidosis, then I remember that previous time I discussed the case with Jack, I realized that sometimes, elevated lactic acid level doesn't always point to ischemia, because, in our mind, we always think that when we get lactic acidosis, then there has to be a component of mesenteric ischemia. And, in our case, it definitely warrants suspicion, because sometimes it can seem that the physical examination findings are out of proportion to the pain thing. So definitely I would look for the mesenteric ischemia. But apart from that, any abdominal condition, if it is severe enough to cause the inflammation, which can cause spastic pain that our patient is experiencing, and often it happens that lactic acid is elevated. And, our patient is an alcoholic. Now, as Travis mentioned, that the patient drinks alcohol only occasionally, but still, it makes me wonder that what if the patient had some alcohol recently, and maybe, that is also contributing to the elevated lactic acid levels. And finally, I wanted to, come back to Jack before we highlight the chat thoughts, that in the past medical history, we had the element of nausea and vomiting. So Jack, how can we incorporate nausea and vomiting in our thinking? And then you can guide us further.
I think it's a great question. I would say the nausea and vomiting, we can sort of incorporate it in one of two pathways. I think one pathway that we can say, or that we could take is say that this is suggestive that there is something causing an underlying enteritis, right? So actually the part of the intra-abdominal space that is inflamed is the gastrointestinal tract, and particularly the upper gastrointestinal tract, whether that's the stomach or the small intestine, right? So we could say that the nausea and vomiting has some localizing feature to what organ may be inflamed. But I think the other thing is that sometimes nausea and vomiting is a manifestation of severe systemic illness, or systemic illness that's not necessarily related to a specific area within the GI tract, right? We see that sometimes individuals, when they're experiencing severe pain from, say, a fall or trauma, that we may see some emesis that happens there. So I think I'm struggling to reconcile, like, is the nausea and vomiting going to be signal that there's a process happening within the stomach or the small bowel, or is the nausea and vomiting just signal that there is something really bad happening in the abdomen, and that could be anywhere along the way? I think a lot of this can become conjecture, because we're going to sort of need cross-sectional imaging to really get an understanding of this. But it's totally plausible that we could see something like a perforated gastric ulcer, which could certainly give somebody nausea and vomiting. We could see a perforated duodenal ulcer, which could give somebody nausea and vomiting and also peritonitis. But we might see that actually the appendix or the colon or something more distal is on the hook, which is harder to link directly to nausea and vomiting, but certainly easy to link to acute peritonitis leading to nausea and vomiting. And so I think the things that we're going to be looking for on the CT scan that I hope is going to be coming is going to be, one, is there ischemia to any part of the GI tract, as you mentioned? Can we see signs of organ-based inflammation, whether that's the gallbladder, the pancreas, the appendix, the small bowel, or the large bowel? Or do we see something else like an obstructive process and a transition point somewhere? But I think those are going to be the three things we're looking for: ischemia, perforation, organ-based inflammation, or obstruction, right? To take us back to that that original framework we had, a lot of those questions can be answered with the cross-sectional imaging. Because exactly as you said, Kirtan, any of those processes could give us the high white count and the high lactic acid, but we don't necessarily have a good signature for specific organ-based inflammation, right? The LFTs are normal. We don't see a high alk phos or T-billy, and the lipase is normal. And those are usually the organs that will show up on laboratory evaluation, right? But we don't have good tests to look for bowel inflammation, whether that's small bowel or large bowel. And so I'm wondering if one of those organs or one of the things coming off of those organs, like the appendix, is going to be on the hook here.
Sure. Sounds awesome. And Travis, do you think that you can give us next letter, or maybe we can highlight the chat points, maybe if you think time is still there?
You want to next aliquot?
Do you think like we still have enough time? Then we can maybe, highlight chat's point first.
Yeah. No. I have basically the CT scan next I'm going to show you, and then kind of what happened next. And so you tell me, if you wanted me to kind of share the CT and the results, and then we can have a discussion, and then we can talk about the hospital course.
Yeah, sure. Before we can move ahead, I can, ask Daniela to unmute herself if she is in a place, because the point that she is raising is certainly important. And I think one of the cases by Travis himself has been regarding this in the past. So Daniela, please, if you're in a place you can unmute yourself, then please share your thoughts.
And if not, Danielle, if you just hop on, just interrupt me. This isn't gonna kind of disclose anything from the case, but Kirtan was talking about the white blood cell count, and Jack was as well, as kind of increases our suspicion, of some sort of itis. I think everyone reflexively, including myself, you see a high white count and you think infection, right? In reality, I've seen appendicitis with a normal white count, cholecystitis with a normal white count, all of these things with normal white counts. And, if you take likelihood ratios into account on kind of weighting data that would suggest a diagnosis, an elevated white count for appendicitis, on a scale of 1 to 10 might be a 2, which, it might increase the likelihood of it maybe 15%, whereas 5 is a 30%, and a 10 would be almost a rule-in type of diagnosis. At the same point, if the white count is normal, we assign it a minus 10 or a 0.1. That would be a rule out. It does not rule out the presence of appendicitis. I bet you that would be more like a 0.5 or something that decreases the likelihood by about 15%. So at the same time, the white count suggests it, but it doesn't rule it out if it's not present. And, it's one of those things. I think it took me a long time to realize, like, oh, hey, the white count's normal. It's not appendicitis. It might decrease the likelihood of it being there, but you should not kind of pull that off your differential diagnosis, if that makes sense, with all of these things. And so that's one of the things, that, people taught me going through my learning, was just utilizing data and either suggesting or decreasing the likelihood of something, and relying on that white count to do those things is something that we could trap ourselves into making a clinical reasoning mistake. And reflecting on cognitive autopsy, you'll say, you know what? I should have still kept that up there on my differential. I shouldn't have moved it down as far as I did.
That's amazing, Travis. And I think, maybe Daniela isn't in a place where she can unmute herself. So why don't you go ahead and share your next aliquot, Travis?
Perfect. Could you make me the co-host real quick? And I have some images to show. Perfect.
While Travis is pulling up the images here, I think one other point, maybe not necessarily from a diagnostic reasoning standpoint, but more from a management reasoning standpoint, is sort of thinking about who, as an internist, we would want to get involved to help here. And I would say with that exam, even before the patient goes to the CT scan, it's worth getting a general surgeon involved, so that she can bring her expertise and say, based off of this abdominal exam, here is what I'm worried about. Based off of her impression of the patient's exam and how the abdomen feels, can sort of frame, sometimes we actually might go straight from the exam to the OR and actually skip the CT scan, because the probability of an intra-abdominal catastrophe is so high. And so in addition to thinking about what tests we want to get, it's also what expertise we want to bring in. And I think having a general surgeon's eyes and hands on a patient who we're worried about having an intra-abdominal catastrophe can be super helpful, because she'll bring so much expertise and so much experience to deciding, is this peritonitis that we need to take to the OR now, or is this peritonitis that we need to wait to go and get a CT scan for? But Travis, go ahead and take us through the images that we have here.
Perfect. So we obtained a CT contrast with IV only contrast. We did not do oral contrast. We did not want to wait the hour to see what was going on, considering how our pretest probability was that she had, some sort of perforated viscus or something like that. So we wanted to kind of figure out, we didn't necessarily want to wait. So her CT scan here is shown. And so these are axial images showing some distended bowel loops. And I'll give you another coronal view of her CT scan. And the report was read as this: her pelvic organs were unremarkable, notable for a hysterectomy. Her hepatobiliary system was unremarkable. Spleen was unremarkable. No lymph node enlargement. Her vessels showed marked atherosclerotic plaques throughout the aorta and infrarenal AAA measuring an infrarenal AAA measuring 3.7 by 4.1 centimeters. In the peritoneum, there was a small amount of free fluid noted in the pelvis. And on the GI section, there were multiple dilated loops of small bowel noted. The terminal ileum appears decompressed and thick-walled. Findings concerning for early or partial obstruction, secondary to terminal ileitis, appendix not visualized, with gas noted throughout the colon, but not within the colon wall. So that is the CT scan report. And I didn't know if you wanted to discuss the findings, and afterwards I can kind of go through the case.
Sure, that sounds great. Kirtan, take it away.
Sure. So firstly, as Travis mentioned that, there were some air fluid levels and there was some evidence of obstruction. So the presence of air fluid levels definitely raises the suspicion that definitely we are dealing with the obstruction. And, while back in the chat, I was mentioning that as Jack kind of hinted us earlier, that when we have involvement of right lower quadrant, then what are some of the organs that we have to think about? So appendicitis is definitely possible, and ileitis is possible, and the initial part of the ascending colon, that is involvement of cecum, is possible. And if you think about it, then all three of those organs are those organs which can often get inflamed, which can often get obstructed due to numerous reasons. It could be some infection like tuberculosis. It could be, a lymphadenopathy like malignancy is there, or lymphoma is there, which is causing the obstruction. Or it could be just the run-of-the-mill inflammation is there. It may or may not be associated with IBD or any other autoimmune disease, but definitely inflammation can lead to obstruction in those regions because the caliber in ileum is very less. So that region is prone to get obstructed and prone to form inflammation, which can subsequently undergo the infarction and can undergo perforation. And why I'm telling the infarction part, because Travis kind of, discreetly mentioned that throughout the patient's abdominal aorta and the infrarenal branches, there was evidence of atherosclerosis. So as we discussed in the earlier aliquot, that elevated lactic acid is there, which can definitely point us to the possibility of mesenteric ischemia. And whenever you have ischemia, you will get inflammation. So of course, the ileitis is there, which can raise the suspicion for any other condition causing the inflammation. But ischemia itself, if the mesenteric vessels are involved, like superior mesenteric and inferior mesenteric vessels, then it can lead to inflammation, which can subsequently undergo the perforation. So that is something which is worrying me. And finally, I would also comment on one important point, which I had learned from the VMRs only, like few months back, that whenever we have intra-abdominal catastrophic kind of thing, peritonitis is there, and we have to predict that in future, what if the patient develops, something like portal vein thrombophlebitis? Because, when you have the infection swarming in the peritoneum, and there is a very high chance that portal vein can get involved, and then subsequently, septic embolia can go to the liver and can often be a cause of fever of unknown origin. So what Jack mentioned earlier, that the management is absolutely key. The time is very essential, and we will involve the surgery, we will involve the radiology as soon as possible and see that what are their thoughts regarding the management. And Jack, now, please take us home, that what are some of your points regarding this?
I think that your analysis of the imaging findings in terms of the underlying etiology is absolutely brilliant. And so I really have nothing to add there. I think exactly as you said, appendicitis is on the hook, ileitis is on the hook. Whenever we see inflammation of sort of any part of the distal GI tract, we sort of can think about the 4 I's. And that could be exactly as you mentioned, ischemia, infection, non-infectious itis, and then rarely we can have something like an infiltrative disease process. But I think given the time course that you mentioned here, those first 2 I's or I guess those first 3 I's, ischemia, infection, or non-infectious inflammation, which we can sometimes see, right? Not all cases of appendicitis are going to be septic. There could just be some sort of obstruction of the vascular bed. Like those things are all going to be on the hook. I think where sort of where my brain is going in terms of thinking about how do we manage this, right? Because there's sort of 2 primary ways that we can manage what seems to be a bowel obstruction with signs of peritonitis, right? One way that we can manage it is conservatively and say we're going to make the patient NPO, we're going to give them IV fluids, we're going to maybe put in an NG tube to try to help decompress the bowel and hopefully see if this resolves, because we don't see signs of a complete obstruction yet, so things may open up and resolve. The other pathway that we can go would be something that would be less conservative and require sort of more urgent interventions, which is going to be an exploratory laparotomy. And in that case, that would be something that we might do because we feel like we have to lyse adhesions that could be there or repair a part of the bowel wall that has been compromised. And so I think one of the things that I was listening for and looking for on the imaging is, do we have signs that this is not going to be something that's going to respond to conservative management? Or do we have signs that the bowel wall has been compromised? And one of the things that I think jumped out to me was the fact that there's trace-free fluid within the pelvis. And that could be related to just the fact that the GI tract is inflamed. And so we're bringing some sort of fluid and edema. And so we're getting sort of some free fluid in there just from nearby inflammation. But the other thing that we have to be open to is actually that there is possibly a small perforation that has happened, and we're actually leaking bowel contents into the peritoneal space. We don't see some of the hallmark findings of a GI perforation, right? We don't see I didn't hear that there was sort of a gas within the peritoneum, right? We don't see that there's free air underneath the liver or free air underneath the diaphragm on the other side. So we haven't seen free air make its way into the peritoneum, but just because there's no free air doesn't mean that some sort of intraluminal contents haven't leaked into the peritoneal space. And so this is a space where, as an internist, right, I do not have the expertise or the skill to make that call around this is something that we can manage conservatively, or this is something that needs to go to the OR. Again, the general surgeon is going to bring her expertise to say OR now versus OR later. But I think that's one thing that's helping me frame the importance of getting some extra eyes on the patient and on the CT scan, because that trace-free fluid, again, could just be reactive fluid, or it could be a sign that there has been some perforation happening and that fluid is actually coming from the GI tract itself. And so I think in terms of the underlying etiology, that may be something that we will find out only later, right? Was it the appendix? Was it the vascular system? Both of which I think you articulated brilliantly, Kirtan. And I think alongside that, we have to sort of put on our management reasoning hats and say, what's going to be the safest plan for this patient? NG2, decompression, NPO, and see if this resolves versus exploratory laparotomy to fix something that may have already ruptured.
Awesome reflections. And I think next time I'm just going to dial you in, Jack and Kirtan, and you can take us through the case. So I'm going to share kind of what we did, and then I have another image to share with everybody. So general surgery was consulted, and in this case was, I think, probably about 9:30, 10 o'clock at night. So calling a surgeon late is met with not resistance, but I think everyone knows, surgeons trying to go to bed, and then you call them to wake them up. But the findings were discussed, and we also discussed how tender she was and how bad her exam was. We were concerned for peritonitis. And so he came in, we kept the patient NPO, placed an NG tube, gave her IV antibiotics, which we gave piperacillin and tazobactam, and lactated ringers, which is the real balanced solution. And she was taken to the operating room. And I think we discussed all the things that you said about an SBO and management, with just keeping someone NPO, NG tube, and see how they are. But he felt that her exam warranted an exploration. And so upon taking her to the OR. This is, can you all see the image? So that was found when they were kind of looking at her bowel, and in the operating room, there was a hole leaking. Bowel contents was visualized by the terminal ileum with what appeared to be a small wooden stick that was sticking through the small bowel, contributing to an intra-abdominal infection. The appendix was visualized, and resection of the distal ileum, proximal colon, with cecum, and primary anastomosis was performed. The peritoneal fluid was sent for culture and grew out Klebsiella and E. coli. Her hospital course, thankfully, was uneventful, and she was sent home after a few days in the hospital. So she had a good outcome.
Wow. Was that a toothpick?
That's what we think. It was a very large wooden stick. It was bigger than the average toothpick, and I don't know what it was, and the patient had no idea either, which was interesting. I have no idea what it was, but it was like a toothpick, the same size, but it was a lot thicker. I mean, almost like was a kebab stick.
Wow. Wow. Well, I think relieved to hear that she ultimately did well, right? If we think about what the overall mortality is for an intra-abdominal or for a perforated intestine in somebody over the age of 60, like that can be a very, very morbid diagnosis to make. And I think it's a testament to how quickly Travis and your team got her sort of underneath the consultation of a surgeon quickly and got her to the OR as quickly as you all did, because it seems like you were sort of able to avoid some of the devastating complications. But I'm curious, any reflections that you have, Pratham?
Sure. So, I wanted to mention just one thing, that how, our initial reflexes were correct and how they kind of saved the patient. So Jack, as soon as we got the examination, Jack mentioned that in this case, I would like to involve the general surgery as soon as possible. And in this case, that was the turning point, because they actually told us that this is something that we need to look into. We can't just, do like NTU and stuff like that. We need to explore her. And that led to the diagnosis. So I think that reflex is very important, that when to seek help from our colleagues, because that can be absolutely, difference between life and death for the patient. And another thing that I wanted to mention, that there was indeed one NEJM case record, very similar, that the patient had toothpick ingestion, but in that case, the only difference was that patient actually remembered that, he had ingested something that was strange. And finally, one last point I wanted to make, that in house MD, there was one house episode in which the patient had all the strange constellation of symptoms, like the patient had pleural effusion, the patient had hepatic abscess, the patient had peritonitis, the patient had back pain. And finally, it was the same thing, the toothpick, and they, kind of explained that, toothpick was kind of migrating all through her body. Like the toothpick, kind of went into the part where it is near to the diaphragm, and it caused irritation to the pleura, leading to hemorrhagic pleural effusion. Then it went to the liver, causing the liver infection. And finally, it went to the peritoneum and it caused the peritonitis. So, very kind of elegant way to think that how this foreign bodies, including bullets, we have seen that sometimes bullets can also, behave in similar way, that they can move to all organs and cause inflammation of many organs. And, that make us think that how we can reconcile all these findings. But again, getting back to the history, getting help from colleagues finally seals the diagnosis, because in this case, that is what happened. So thank you so much, Travis, for, highlighting that point, that how surgeons saved the life of the patient. So thanks for amazing case, and thanks for discussing with me, Jack. It was amazing.
Oh, it was a blast, Pratham. Thank you so much. Before we turn it over to Madalena for the teaching points, I also want to give a huge thank you and a shout out to Sawyer. I want to say that the way that you had organized the board, particularly for the HPI and all those other things, made it super easy to get to think through the case. I don't know about anyone else here, but I sometimes get lost myself reading through the HPI. But I just want to give a huge thank you to you for scribing on this case and also navigating many of the different sort of passing back and forth with Travis, because being able to see the images and see the intraoperative findings, I think really helps to drive home a lot of the learning for this case. So I just wanted to say thank you so much for that. And with that, I will turn it over to Madalena to take us through some of the key teaching points from today.
Wonderful. So what a fantastic, multimedia case presentation and a fantastic discussion. So these teaching points, both myself and Deborah helped to work on these, but I'll just do kind of this out loud presentation at the end. So if we start off with just the chief concern of abdominal pain, we got a really helpful framework for the life-threatening causes that we don't want to miss. So we can use the VIP mnemonic to help remember those. So for V, vascular, we want to think of MI, mesenteric ischemia, aortic dissection, abdominal or aortic aneurysm. The I stands for itis. So itis can be of a lot of different organs, whether it's pancreatitis, cholangitis. The P in the VIPO mnemonic is for perforation. That can be from a gastric or duodenal ulcer. Things, on imaging that would point to that would be signs of gas for free air under the diaphragm. And then the O is for obstruction. We talked about the most common cause being adhesions from a prior surgery in this case. And on imaging for obstruction, we want to look out for air fluid levels. So moving on to the HPI, when we're thinking of trying to localize abdominal pain, that can be very challenging just because the abdominal organs are so close together. And as we know, abdominal pain is not just a sign of pathology in the abdominal organs. We want to think of thoracic causes, gyne causes, even spinal cord. So we just want to be sure that we don't anchor on a problem in the abdominal viscera. Then when we got a little bit more of the review of systems, we talked about what things we can learn when we're characterizing abdominal pain. So if the abdominal pain is worse with movement, we really want to consider peritoneal irritation. And we had this really interesting discussion about kind of where the pain starts and where does it progress. So whether it's local to diffuse or diffuse to local. And we talked about how usually it goes from local to diffuse. And the reason for that is that when it spreads to the visceral peritoneum, there's less innervation, so it's not as good as with localization. However, the outer peritoneum does have more direct innervation, so it is better to localize. So when we see something that goes from a local abdominal pain to a diffuse abdominal pain, we want to think about perforation, which can lead to peritonitis, actually, as in this case. Moving on to the physical exam, we talked about how even with stable vital signs, you don't want to, you still want to have a good amount of suspicion because the signatures can first present on the physical exam even before the vitals. And again, we saw that, if the patient feels pain when the bed moves, that is another sign of peritonitis. Moving on to nausea and vomiting, we talked about how it's a little bit hard to use nausea and vomiting as a big branch point in clinical reasoning because in some sense it can mean an enteritis, but it could also signal a more systemic illness not related to the GI tract. Moving on to labs. So in this case, we saw neutrophilic leukocytosis, which can be consistent with inflammation, but an important point that if the white blood cell count is normal, it does not rule out other itises. We also talked about how an elevated lactate level can cause you to consider ischemia and other inflammation causes. We talked about management too in a patient with kind of this acute abdominal pain, and management including both tests, but also the expertise that you want to get involved. So we talked about getting gen surg involved very early on because if we need to do urgent treatment like an X lab, we need their expertise, but conservative involvement would be something like an NG tube for decompression. Moving on to imaging. So we know that kind of the CT scan is the workhorse for abdominal pain. And on the CT scan, we need to look out for things like ischemia, perforation, organ-based inflammation, signs of obstruction like a transition point. And for inflammation of the distal bowel, which was the case here, we also want to think of those buckets of ischemia, infectious, non-infectious inflammation, and infiltrative. And then Kirtan made this pearl at the end, which I have to look into myself, how peritonitis can lead to portal vein thrombophlebitis. So I will have to dig into that pearl, but overall, amazing case discussion.
Awesome. Thank you so much, Madalena. Absolutely phenomenal teaching points as always. I want to elevate Kirtan's point in the chat too, and just say one final welcome to all of those who joined us for the first time. Arush, Ian, Camila, Nazanin, Daniela, like all of you, it's so fun to see so many new faces here, and we're just so happy that you were able to join us today. And then I'm going to actually take over the screen for 1 second and turn the mic over to Deborah for a exciting announcement for us coming up here. Give me 1 second here. Can everybody see this okay? You all see the graphic? Cool.
Hi, everyone. And welcome everyone that was here for the first time. I want to announce that on Friday, we are going to have a concert of VMRs. They're gonna be really special for us. We are trying to help people in Ukraine. So everyone, we have 4 options of VMR. You can join anyone that you want, or both, or all the 4s. And yeah, let's contribute and help the way that we can, like with just some from distance. So everyone, it's welcome on Friday.
Thank you so much, Deborah. We hope to see you there. And if you see Sukriti Bantia on Twitter or anywhere else at VMR, please also give her a huge thank you, Sukriti. And so many team members have put in an enormous amount of work to organize this for Friday. And we really hope to be able to see you there. But thank you so much for sharing that with us, Deborah. And I hope everybody has a great day. We'll see you soon.
Bye.
Bye, everybody.